Otherwise, happy to chat today about this. This technology is actually pretty homegrown here. It's a combination of a couple of things, but the fusion of techniques in particular to hopefully help our patients here at UCSF Epilepsy Center and potentially other institutions. So it's got this big long name, accuracy of omniplanar and surface casting of epileptiform activity, but we just call it Ictal Cinema for short. And I'll go into this description a little bit, but the idea is that, there's a lot of information in these really big, important studies that we do. And like with what you just saw from Dr. Knowlton, combining that into an image or a couple of images that you can interpret more intuitively is super key to really try to take in that data and really have it help the patient. So, standard disclosure size, there's no disclosures, and everything you see here is completely open source code. I'm happy to give any code to anybody. We really just want this to help people. And I'm funded by a couple of grants here, one in particular from the Weil Institute here at UCSF that gave me a pilot award to help see this study to fruition. So going way back, almost a century ago now, the first brainwaves were recorded from the human brain. And this is on Wikipedia, you can even see it. It's a little squiggle of like that trace there, it's a squiggle. And this person, Hans Berger here, was the first one to do it. And he put like a sine wave, which just means like a regular consistent frequency wave right below it to show that the human brain is actually generating these cycles of activity. And so that was the first brainwave recorded on a little strip of paper with one electrode. And it was in the back of somebody's head. I think it was a relative of his, actually. So just one electrode. Pretty easy to interpret, right? Just one electrode, one trace. If it gets like strong signal versus like little signal, it's pretty easy to tell the difference. But then in the decades after that, people started putting a bunch more electrodes because you have to figure out where the seizures are coming from, left to right, back or the front of the brain, and even more, hopefully a smaller focus if you can try to localize it that way. So a couple of people got together and they said, okay, we should just create this system. We'll put electrodes exactly spaced at these points in the head, and that's what this little schematic shows. It's called the 1020 system. It's invented in 1957. And that's what we use literally through today. Anytime someone has a scalp EEG at our center here, any other center worldwide, actually, they put these electrodes in these locations. And they may put more electrodes like what you saw with Dr. Knowlton just now, but this is the standard system. This is really helpful for us to interpret these brainwaves because we know how they're gonna appear on the screen, in which order, and then we can tell just by looking at a quick shot here of this is just 5 seconds of data of brainwaves. We can tell where that's where things are coming from and what things are. But that's scalp EEG. Intracranial EEG is something very different, and you may have heard already today a couple of times that, including from Dr. Knowlton, that sometimes patients have really difficult seizures that you can't control with medicines, or at least it's very unlikely that they'll get good control with medicines. They've already tried multiple, and they're terrible seizures. Really, they affect their life so much, impact them, and they're potentially dangerous seizures. So sometimes we do this study where we think really deeply about this. We take a lot of different information and scans, like you just saw, together and say, okay, it looks like the seizure is coming from this general area in a particular patient, and we would actually have our surgeon, he would implant electrodes that go around the brain and are actually directly on the surface. That's what this looks like here. This is one of our patients, and of course I'm not revealing any identity here, but that's their actual brain reconstructed in 3D, which we can do now with some really cool biomedical imaging tools. And we can also figure out exactly where our surgeon put the electrodes. We know where we want them to go, but once they're actually in, we want to generate these pictures that tell us exactly where those electrodes are in relation to that patient's specific anatomy. So it's really neat. We can see where these electrodes are, and then we can record from them. And when the person has a seizure, we can hopefully say, it's right here, like this particular electrode lights up first. That's the one that it looks like that's the seizure onset zone. That's the bad part that we would want to take out to try to stop their epilepsy. In some cases, we can even cure their epilepsy with this sort of a surgery. But we really have to be able to interpret this data. So you can already see that there's a lot of electrodes here. These blue dots are the electrodes. And that's just one patient. This image right here is the person's brain. If you rotate it down, look at the bottom of the brain, and I just made the brain actually clear here, just using some fancy tools here on the computer. this is sort of like a glass brain, we call it. And inside, this is the hippocampus structure and the amygdala structure. Those are two common areas that we see seizures start in. So this is one patient. If I give you a completely different patient, completely different location of the electrodes, where they are, I mean, even the hemisphere, and this person's different anatomy parts of their brain are also very completely different than this other person. So every single person is going to have their own specific anatomy. They're going to have their own specific layout of where the electrodes are. And I made this table here to just kind of talk about all the different things that are different from patient to patient when we do these studies. So, so this is a problem, right? Because this is what the data looks like. This is what we call an intracranial clinical montage, which just means that there's 182 channels in this particular person's study, their recording study. Again, it's just like a scalp EEG, except these people are implanted with electrodes and they stay with us in the hospital for a few days or a week sometimes or more until we record a seizure. This is just 10 seconds of data. So time is down here on the x-axis, 0 through 10 seconds. And then on the y-axis is a bunch of different recording channels, 182. You can imagine this is kind of tough to interpret, right? Where are the brain signals coming from? Like this electrode up here is, this channel number 5 is giving this signal, but where is channel number 5? I have to go back to this map here and say, oh, okay, it's right over here. Well, what about this? It looks like there's maybe some bursts of activity happening right here. What are those electrodes? We have to go back to the map and figure out where they are. We're going to go back and forth, back and forth. You get the idea. So this is a lot to interpret. And sometimes when we get this data right off the bat, we're like, whoa, this is pretty crazy. I grew up in the 80s, so I had to throw some Bill and Ted in there. But we really think, whoa, this is a lot of info. So we have to knuckle down and really spend some time understanding it. Of course, we get a really excellent handle on it. Don't get me wrong. It just, it takes time and a lot of effort to make sure that we know exactly where all the seizure activity is coming from, which to me doesn't sound, it didn't even sound that efficient when I was a trainee. I was like, boy, every patient's different. There has to be a better system. This is a clinical recording. This is actually with our new research grids that Dr. Chang, our epilepsy surgeon, uses. If we were to look at all the electrodes, this is 338 channels. To that, you might say, double whoa. That's a lot of information. So just to kind of summarize, 100 years ago, not even, it was one channel, and we knew exactly where it was. For scalp EEG, it's 19 channels consistently, and we know where those are. For the intracranial EEG, it's over 100 channels often. And for the new research sort of electrode recordings, which may actually become the future of epilepsy recordings, those are hundreds of channels. And you can see the difference. It seems kind of crazy that we go through all this data and interpret it all, right? We definitely do. We scrutinize it very highly with a whole team of surgeons, neurologists, trained epileptologists, fellows, neuroradiologists. But wouldn't it be nice if we could take all this info, these pages of data, and instead of having to figure out, what the brain would look like or where the electrodes might be, because I couldn't even tell you whether this data came from this person or this person, wouldn't it be great if we could just take this data and just project it on a brain and have it tell us exactly where the bad seizure activity is coming from, like a heat map? So that was the idea that I had back in residency, listening to the sort of going back and forth of the people that knew about the recordings, explaining it to the rest of the team so that everyone could interpret it. It was a long process, and I said, boy, wouldn't it be great to speed this up with sort of a heat map and project it? Although that was very complicated, and I didn't even realize how complicated it would be until I started to try to make this a reality with some software that we coded here, that I coded here, along with some help from some other people too that helped me along the way a lot. But I was thinking first, like, someone must have done this before, and in fact, a group over at Yale had at least tried this before. They looked at a part of the signal. It's called like signal power, and I won't get too technical here. I'll really try not to, but essentially, we need a way to say, okay, when the signal looks like, meaning the brainwave looks like this, it needs to be a hot signal. When it looks like nice and regular like that, it needs to be a cold signal or no heat at all. But what do we use to say make it hot versus make it a bright color versus make it a normal color? So this group over at Yale tried to do the power of the signal, which is of the brainwave, which is if you look at this brainwave down here, it starts to get kind of active here and rhythmic, like up and downs that are consistent several times a second. And they looked at how big those ups and downs go, like the height of those peaks and the trough of those valleys. So here's a height of the peak is getting pretty high here, and a trough is low here. So when it gets big like this, you could say, all right, that's the power of the signal, like the potency. Why don't we use that as a quantity? We could say, whenever that gets really big, especially if it goes above these lines, that means let's make it like a really strong, like red color or a yellow color. So that's what they did here for this study. And I won't belabor you with the details here, but you can see that it takes 15 brains here to show you where the seizure is starting. They had to show the different cycles of the brainwave. We call it frequency. So if the frequency was fast, like the brainwave was moving up and down really fast, it would be these brains over here. If it was moving up and down very slow, it'd be these brains over here. And then they had to like increase the potency like higher or lower with, you know, their heat map software. And it would essentially take 15 brains and looking at all of them to try to figure out where the seizure is at that moment. That's way too complicated, way too complicated. We need something that just says, okay, if the signal looks like it's something related with epilepsy, like an epileptic burst, make it a strong color. If it looks normal, leave it as a normal color. So that's where I try to use this thing called line length. And again, not to get too technical, but basically this right here, this black trace is what we call normal activity. It's just like low, it's moving very casually, softly. That's fine. And I put like the little dots here as the data points that are recorded. And there's not really much distance between those points. But if you have this blue trace, all of a sudden there's a big spike. We literally call those spikes. And the distance between those points is long. You can actually see the lines between them, especially when it's this strong dip here. Okay, and then this red trace here is like activity goes up and down really fast. Even though it's not that high, it still goes up and down really fast. That's the blue trace and the red trace. Those are things that we associate with bad activity in the brain that's related to seizures. So we want to be able to differentiate between the blue and red versus the black trace. And what we do is we actually use this little, it's just use simple math and use a math quantity that it's like it's stretching out this line. So here's that spike. If we just stretch this line out, it's actually pretty long, right? If we were to stretch this black line out, it's not very long at all. So let's look down here. If I stretch these lines out to their max, this black line is really short because remember the distance between those points is short. The blue line is pretty short over here, but then at that spike part right here, it's long and then it gets short again, but it's still longer overall than the normal brain activity. And then the red trace is really long just all the way through because the distance between these points stays long no matter what. So essentially, this is a nice little quick way to transform the data, for lack of a better word, from brainwaves on the screen into something that we can say, the higher that quantity is, the more likely it is to be bad activity. So let's put colors to those and project them on the brain. We'll skip through this, it's the same slide. Oh, actually, I'm on the wrong, sorry, one moment, let me just pull that back out. Where was I? There we go. Forgot to take those slides out. Here again, sorry. All right, hopefully you can see my screen. If not, please give me a shout. So all we do is we take these signals here. This is just a couple more examples of a burst, and we convert it to that thing that I called line length because it's like looking at the length of the line. We convert it to a color. The higher it is, the more blue or even the more pink it becomes. And so we take that and we have our brain that we saw before, that nice brain that's created from all our imaging, and we combine the two, we fuse them. And whichever electrodes show strong activity, they're going to be painted pink. The ones that show medium activity will be painted blue. And the ones that show like normal activity will just remain like the same gray or white color as they were before, so you wouldn't really see it. So that's the technology here. And here's just an example of one of our videos for a patient. And this brain here, just keep your eye up here, actually. This patient had a couple of grids put over their temporal lobes, basically towards the back of the brain, temporal and parietal area, and then parietal and occipital. And these are areas like this is a language associated area here. This is their vision associated area back here. And we've got a bunch of other views of the brain here just to kind of help as a little supplement. But what this technology does is it doesn't just show you a picture. It takes a long seizure. This seizure in particular was 8 minutes long, actually, from start to finish, and converts it to a movie. That's why we call it Ictal Cinema. So let's just watch a projection of this data from the seizure, which is all these traces here. Whatever's in this gray box here is going to be projected as a heat map right here at that moment. So I'm going to go ahead and start that video. And you can see that the seizure starts here, right towards the back of the brain between the temporal and occipital lobes. And at that point, the patient's actually seeing a visual aura enlarged in their right visual field, meaning that's their aura of their seizure. They see a little sort of a visual phenomena. The seizure is spreading across the brain, as you can see. And we know that from looking at the traces, but it's much more easy to just look at this video and kind of see exactly where it's traveling. Now it's spreading up towards the language area over here, and that makes him no longer able to understand speech. So I was in the room at this point trying to speak with him, and the patient couldn't actually talk back, or at least couldn't hear me. But he could still say things until it spread over here, and it's beyond the reach of our electrodes right now. But we know at this point it probably spread into his speech producing areas. And then at this point, the seizure gets, just kind of hangs there, but even continues to spread. And then it gets really strong, what we call the tonic phase of the seizure. And then this sort of jerking is the little clonic phase of the seizure, and then it's done. So I apologize if there's some flashing lights there. I profusely apologize. There are a couple of flashing lights in some of these videos. So if anyone has any sensitivity, please, I'll give another warning before I show any more videos. So sorry about that. So that was just sort of a general 1 minute view of this 8 minute seizure here. Okay. And then another thing that we do with this technology is, how do we look at areas that are deep in the brain? Areas that are like deep down, especially in that hippocampus or amygdala area that I was describing. It's commonly a seizure onset zone. This just shows you what happens on the surface, right? So what do we do about electrodes that are deep down, such as right here? So this is a slice of the brain in imaging, and you can see that there's electrodes kind of in that little sort of slice. If we take a cross section of the brain, we can see that there's 4 electrodes in the hippocampus area here. So we use this other technology to create these slices of where the electrodes are in the brain, and then fuse them to the rest of the brain's surface here. So it's kind of like a lopped off view, like a loaf of bread almost, if you think about it like that. But that way you can see where the electrodes are in the brain. And if a seizure starts there, then you'll be able to see it, because we just apply the same heat map technology to these slices, and then continue to watch where it goes with the rest of the brain too. So this is the part that we refer to as the omniplanar. Omni just means kind of like all or every, and then plane is just a plane. Planar is plane. So omniplanar, or any kind of plane, no matter where the electrodes are going through the brain, we create a slice across the brain that's parallel to it, that allows us to see the anatomy, the patient's specific anatomy that's right around those electrodes. So here's an example of a patient that had 5 different depth electrodes, meaning electrodes that were inserted into the tissue because that's where we thought the seizures were coming from, but we needed to verify to try to lead to hopefully curative surgery. And each one of those depth electrodes is colored by a line here, and that corresponds to these slices over here on the right. So that's that was a helpful thing for these deep onset electrodes. I'm going to show another video. I don't really think this one flashes much at all. Might be a little. So you'll see the heat map kind of start up here. I'm going to try to pause it when it does. When seizure onset right now. So if you look down here, these are electrodes that are in the amygdala and then the hippocampus in this section right here. And we can see that it looks like the seizure started there. We can tell in these traces that a seizure started, but now this technology allows us to see where. If we look at the surfaces of the brain here, here's the right side of the surface. If we rotate that around, we can see kind of like the inside part of it. This is kind of behind the ear, but a few centimeters deep. And right within there in this tissue is these areas, the amygdala and the hippocampus. So, and then this is the underside of the brain, the same thing, like this area right here corresponds to this area right here. So we have many different views at the same time, and that allows us to go back and forth through the data as much as we want to watch how the seizure is spreading. And you can see this one spreads, spread up the brain like that. You can already tell some of these seizures actually spread pretty quickly. Some of them spread really slowly. And we see that a lot of time depending on the patient's seizure type. So here's another example. And this is one of my favorite examples of where we use this technology. And there was just an article put out a couple of months ago about a patient. If you get a chance, if you just wanted to look up this technology here at UCSF, we had a patient, this is her, and she benefited from this technology because it helped us kind of interpret the data a bit more. So here's her seizure activity. I'm putting this really slow, kind of slow motion because, and I'll kind of jump ahead a little bit actually too, because she just has some bursts of activity. But once her seizure starts, and again, there's going to be a little bit of kind of sort of flashing here. So just if anyone's sensitive, please maybe avert your eyes a little bit. So her seizures actually started right here in this similar region as that last patient I showed you. But they stayed there, but we also thought before her surgery here, before her electrodes were implanted, that she had two seizure zones that there are two areas in her brain that started the seizures. We thought one was here, or like inside here, which we see is actually a seizure focus. We also thought one was up here, because actually Dr. Knowlton and our read of the actual brainwave data, it was pointing to this source up here too, like an independent source. If you have two independent sources of seizures, that's a big problem, because it usually means that we can't really remove two areas that are causing seizures, or at least that would be a really difficult seizure and then potentially not effective. We really we hope that someone has just one single spot that generates their seizures. It looks like this spot is definitely an ongoing seizure focus for this patient, but watch up here. You see that activity that kind of comes from here and it flashes back over there? It'll kind of flash again here, going backwards. So that activity, if you look down the depth electrodes, this electrode right here is actually put right towards where this seizure focus is, and watch that activity right here. It just kind of eventually finds its way up that electrode, and actually when that's occurring, it goes up here and converts back here. So what I'm saying is, for this particular person's seizures, all the activity is really being driven by this one spot, and then every couple of seconds it goes back up and shoots towards the back. That's what we were picking up on her scalp electrodes before this surgery study. And so this study helped us figure out that there weren't two independent focuses or foci. There was one bad spot. It was this area. And she ended up having surgery to treat this area. And we didn't do anything to this area up here. And she's been seizure-free for over 2 years. So we're very happy about that. It's just another vision. So I wanted to also show another example of where else this technology comes in really helpful. Sometimes someone's seizure will start really quickly in a lot of places at once, or at least it seems to us like it's starting from many different parts of the brain at once. But with this technology, with this sort of movie-like technology, we can put it to slow-mo, super slow-mo, like watching an instant replay kind of, but just frame by frame, and see exactly where it starts. So this is a patient who had a lot of electrodes placed over this region, the frontal region here and the temporal region here. And I'm going to play this in super slow-mo. And you can see that the seizure activity up here will actually start from this area, and then it spreads really quickly. That was only about a half a second of actual real time. So burst starts right there and travels across the brain really quickly. But at least with this technology, we can slow it down frame by frame and even see, like I said, where it actually, the main source of the starting is. So yeah. So then I will kind of gloss over this, but basically, this is fun, to see and to look at, but the real question is, does it help people? Can we use it in an intuitive way as clinicians? So we did this study where we had people just either they just watched these videos, and I scrambled all the electrodes here so they didn't know which one was which, but they got to see all the electrodes activity on the brain. And we wanted to see if they could figure out where the seizure onset zone was, where the source of the seizure was. And we compared that to what the actual known seizure onset zone was from each patient's case. And I had a board certified doctor, epilepsy doctor do this, an epilepsy fellow doctor, neurology resident doctor, neurosurgery resident doctor, all the way down to a medical student. So spanning a lot of different training levels and professional levels. And we had them look at 41 different patients cases. And there's a fun fact, we now have over 100, it's actually over 115 patients in our Ictal Cinema library of videos of patients' seizures like this. And this is kind of what they saw, except they saw the blinded version where this channel order was randomized. And it turned out that there was pretty good accuracy for them localizing where things were. It was above 90% for figuring out which lobe of the brain the seizures came from, just from the videos alone. And then for the actual focus, it was not quite as good as the lobe, because getting the distinct focus is a pretty tough thing, even for our regular technology that we use. But it was still pretty good. And it didn't actually change much between the different levels of training. So that tells us that it's intuitive for the entire team. It can really help, watching these videos can really help bring the whole team to an understanding of like, okay, we know where these electrodes are. These are the ones that are active. These are probably the ones we need to target for hopefully a potential curative surgery. So I won't going to go through all this data, but these graphs are from our recent study that we just put out earlier this year in the journal Epilepsy. And we even made the cover. We were like super stoked about that. So, but it seemed like people found it a pretty helpful technology. We currently use this in the Epilepsy Center just as an adjunct. We don't put all of our money on this by any means. It's just a helpful adjunct to help us interpret the data along with the standard technologies that we always use. But a future direction is to change this into some sort of a fully integrated software platform where, if I'm reviewing a case and, I would usually just review all the EEG data, I can have a bunch of doohickeys and tools here to just rotate the brain, to play it, to watch what it's doing over time. And again, there's maybe a little bit of flashing here, just FYI. But to be able to rotate the brain in sort of real time at will and see exactly how that activity is moving across the brain, rather than just only looking at these traces like this. It makes it a lot more intuitive that way. So yeah, those are the main innovations. There's a simplified way to project a heat map on the brain of seizure activity, and then having these slice views is really, we found really helpful. And then again, as I said in the beginning, all the code for this is based in MATLAB, and it's open source. It's on GitHub, and we even have the data for it available if people try to recreate this at other institutions and epilepsy centers. And I've gotten several requests now from other institutions for people wanting to work with this software. So we also have these high resolution videos on YouTube. If anyone wants to look them up, you can just look up, the OPSIA technology, just type that in, it'll come right up. So, and then just want to say a special thanks for the development of this technology was really driven by
UCSF
did someone say something?
Cinema. Ictal what? Cinema.
Oh.
Yeah.
I think so, yeah. So yeah, this was driven basically by a lot of really awesome people that helped encourage its development to me. Like I was really trying hard to make it happen, and it's really difficult to code this, I must say, but I got a lot of encouragement from many people, including especially Dr. Knowlton and Dr. Chang, our surgeon, and also Ben Speedo helped a lot with making those Omniplaner views in other parts of the software. And then Liberty Hamilton also just making these heat maps into a much more intuitive view. But also, and other people, Max Bod, Simon Emanuel, and really everybody else in the Epilepsy Center has been just so helpful for giving feedback over the years as this has been in development to make this much more refined and useful. So great, thanks very much for having me on this. I think I'm over by a few minutes. So if there's any questions, please let me know.